So how many times in your clinical practice you have come across condition in which very worried parents or a worried mom comes, brings her child to you and says, look, doctor, here my child is passing blood in his stools, or I was changing his nappy and this is what I found. He just passed blood and she's very much worried. What happened to my baby? So I think most of you can relate with this situation. So the question is, if somebody says my child has got blood in the stool or they have found blood in the diaper, now what would you do? How far you need to go into in your investigations? How would you talk to that mother? How would you examine that child? And how would you reassure them? Okay, would you worry about this condition or not? So in today's topic, we would be focusing on a rectal bleeding in children, which usually the parents present their child with by saying that they have found that there is blood in his stools or the child has been passing blood in his stools. So let's get started. Now, it is not very uncommon to come across this condition in which, as I said, the parent would bring their kids and they say like they have found blood or the child is passing blood in his poo. The differentials of this condition are very broad, very broad. There are so many causes of lower GI bleeding in children. But to sum it up, like how would we remember all these things and how would we know? It's become easy if we try to divide the causes according to the age groups of the children. So the age groups that we usually classify when we talk about rectal bleeding or lower GI bleeding is the neonates group, the infants or the preschooler group, and the older children and the adolescents. So these three categories: neonates, infants and preschoolers, and the older children. And then again, it depends that these kids, whether they are well looking or whether they are unwell. So based on this, then it's easy to group the different causes and reach sort of a diagnosis to see what has been causing this lower GI bleed. So I will show you this picture. And this picture is dividing the causes. Again, this is not an exhaustive list. This is just talking about some of the most common causes that you would see in emergency department or a children's emergency department or any acute pediatric setting. So it depends whether that child is well or unwell. And again, what is the age group of that child? Whether you would classify him as a neonate, less than 28 days of age, whether he's an infant between 1 month and 1 year, and old preschooler also like come in this group. So let's say up to 5 years of age. And then the older children, let's say 5 years and beyond, going up to adolescence and, sort of even like beginning of the adult age, that is 18 years. So if you look at this picture, in neonates, again, because most of the time we see this complaint in neonates and mostly parents are more worried when it comes to their newborns. So remember, one of the most commonest causes of this finding blood in the stools or simply finding something red, let me put it this way, finding something red in the diaper. It's important in neonates, if he's well looking, you just look at the diaper. Most of these parents would bring the diaper as well. And you look at the diaper. If the diaper is just red stained or pink stained, I mean, you feel like that the reddish material is not mixed in that poo of the baby. It's just the stain on the diaper. Remember, it is not coming from the stools. It is either passed from the urinary tract or the vaginal tract. Now, the most common cause is swallowed maternal blood. Now, these units, because they've been born, let's say 1 or 2 or 3 days before they present, what has happened basically? Either when these babies were breastfed, there was a crack in the nipple and they swallowed some blood, and because of the low transit time, it just went down and presented in their or sometimes what happens is that they can swallow some maternal blood while being pass through the vaginal tract, and that can also come down and present as like blood in the stools. But as I said, these conditions where they have swallowed maternal blood either through the nipple or while passing through the vaginal tract, that would be mixed with the stool material. But if it's just staining, one of the commonest causes of staining are urate crystals. Urate crystals, neonates, they pass urate crystals, and as they come in contact with air, they oxidize and they give a pink staining. So I would show you this diaper. This is the image of a diaper, and here in diaper you can see that this has got some reddish pinkish stains. You see there is no sort of a fecal material which is mixed with that. It's just the staining. It means this has not come from the stool. This has come from somewhere else. So what else could be there? In boys, it would be just urethra. So possibly coming from the urine. And in urine, the most common cause is what? Urate crystals that got oxidized. So urate crystals. If it is females, again, it could be urate crystal. But sometimes it could be sort of a, what you call withdrawal bleeding in urine, because in fetal life, maternal estrogens have worked, and as the baby is born, a female baby, there has been a physiological estrogen withdrawal which was coming from the mother, so that can lead to a bit of bleeding, vaginal bleeding, and again that would stain the diaper. It can sometimes mix with the stool, especially coincidentally if the baby has passed poo as well. But remember that is usually those babies are very well looking. Now, as I said, the most common cause in a well-looking baby is the blood is of maternal origin, because it either the baby sucked it from the nipple or he swallowed it while passing through the birth canal. How can we classify that? The most important test is APT test. So APT test can actually be done on the what you call the baby's blood in the stool, sometimes even in the vomit as well, and that can classify whether this blood is of maternal origin or fetal origin. With a maternal origin, you can just need to give reassurance as these are most common cause. So swallowed maternal blood. So remember, this is actually determined by the AP test. Some babies can pass hard stool as well, and they can develop anal fissure as well. So they cry a lot, they've got constipation, and if you examine their anal opening, you might see a longitudinal tear. So these babies, neonates, are very well looking. So swallowed maternal blood, anal fissure, and the third important cause is cow milk protein allergy, which is actually causing allergic proctocolitis. So cow milk protein allergy is basically allergy to protein molecules. The intestines cells that get inflamed, they cannot absorb it. And in the process of this antigen antibody reaction, like mucosa can be shed, it's inflamed, can cause bleeding. And that bleeding actually presents like what they see reddish in their in the poo of the baby. So cow milk protein allergy, which is usually treated by changing the formula to a hypoallergenic or amino acid based formula. These babies are very well looking. If a neonate is unwell, it's also the first thing very important is to consider hemorrhagic disease of the newborn. Now, in many cases, these babies probably didn't get vitamin K at birth. But it's very important to do a coagulation profile to look at the prothrombin time and the activated partial thrombin plasma, because the coagulation profile is usually deranged if they've got vitamin K deficiency, leading to early or late onset hemorrhagic disease of the newborn. But these babies would be very unwell. Premature babies can develop what we call as necrotizing enterocolitis, in which there is an infection of the intestines, small and large intestines. Very serious condition, very grave condition. These preterm babies are very unwell. They usually have got vomiting, bilious vomiting. They've got abdominal distension. They've got a very toxic appearance. And if you do an X-ray as the first, point of investigations, you might see that there is gaseous distension of the bowels. There is usually intramural gas in the walls of the intestine, or sometimes there could be frank perforation leading to pneumoperitoneum as well, and that can be shown in the X-rays. So necrotizing enterocolitis is a very grave condition, usually happens in prematures, or sometimes a malrotated intestine which can twist on its own axis on the mesentery and lead to valvulus. Again, these babies would be having vomiting, they are very unwell, they would be having abdominal distension, and they can present with some bleeding in their stools as well. So this is about the bleeding causes in neonates, whether they are well or unwell. Now coming down to infants and young adults. Again, the same cow milk protein allergy, which is there in the neonatal period, can go beyond in the infancy as well. And if they get exposed to these milk proteins, they can have this spectrum of symptomatology that contains rectal bleeding as a part of it as well. They would be having vomiting, they would be fussy, they would be having rashes, and as part of, as I said, the whole syndrome, they can present with uh, bleeding in their stools as well. Older children can have viral gastritis. Viral gastritis presents more with vomiting and some hematemesis. Sometimes the blood can go down as well and present as a dark, material, brownish reddish material in their stools. As viral gastritis is again, but these kids are usually well looking. Infectious gastroenteritis, viral or bacterial or whatever. Again, these kids are well, but they have got vomiting, they've got abdominal pain, they can have sometimes bleeding in their stools as well. Now, if this an infant or a young child looks very unwell, then you have to think about some other sinister causes. One of the important causes that you should never miss in an infant is intussusception. Intussusception is a part of telescoping of the intestine into another part. So the part of the intestine just like invaginates into another part of the intestine, leading to ischemia and sometimes necrosis as well. And this thing usually present between 3 to 9 or 12 months of age. These kids, they are irritable. They get like attacks of crying, inconsolable crying, lethargic. Then they are fine. Then they again go back in the same thing as the ischemia develops. Some people say about the red currant jelly stool, that is usually a very late sign and quite uncommon. But usually sometimes they can present with like sort of bleeding in their stools as well. So intussusception you should always think about and rule out. There are some other reasons. Meckel's diverticulum. Like Meckel's diverticulum is not a very common thing. They say it occurs in 2% of the population. It's 2 inches in size and 2 feet from the ileocecal valve, just what we call as a rule of twos. So this is an outpoaching. I think it's a remnant of vitello-intestinal duct, which connects actually intestine with the yolk sac, and it can contain the gastric mucosa. So you've got like acid-producing mucosa lying in the center of the intestine. So that acid can burn these cells, surrounding intestinal cells, and can cause bleeding. So usually painless, massive bleeding in preschoolers is Meckel's diverticulum bleeding. And it's very difficult to diagnose because the only way you can diagnose is by technetium-99 scan or a radiolabel RBC scan. But they usually have got episodes of painless, massive GI bleeding, lower GI bleeding, and most of the time they're well. But if they've got repeated episodes, they might be very unwell, like pale and looking really like, sort of can present in shock as well. So Meckel's diverticulum is one thing that you should consider if a child is unwell and has got massive painless bleeding. Vascular malformation, angiodysplasia. Sometimes the blood vessels have not developed properly and they have got a tendency to bleed, leading to repeated bleeding from the intestines, leading to repeated episodes of rectal bleeding. So again, they would be very unwell if it is happening again and again and again. In older children, 5 years and beyond into adolescent age, again, if they are well, viral gastritis can happen in these kids. Again, as I said, like would present with vomiting and maybe like hematemesis, malarious tuberculosis can present with lower GI bleeding as well. Again, the same infectious gastroenteritis, viral or bacterial can sometimes present with. Another important cause in these, older children is constipation-induced anal fissures or hemorrhoids as well. So if they've got anal fissure, they would be having painful defecation. They usually present that there is fresh blood on the top of the stool. So the blood is not mixed in the stools, which usually, because if the blood is mixed in the stool, it usually means that the blood is coming from high up in the intestine. But if it's just on top of well-formed stools, it simply means that it's coming from lower down. So either close to the anal opening. It's either from the, let's say, from the rectum, or from the anal canal. So it could be because of bleed from the polyps, solitary or juvenile rectal polyps. It could be because of the anal fissure, which is a longitudinal fissure because caused by constipation, quite painful. Or it could be because of hemorrhoids, which are just congested veins in the anal canal. So they can cause bleeding. Usually they say either when they pass stools at the end, they notice that there is fresh blood trickling from their bottom, or there is fresh blood on top of the stools, or they might find like blood when they are wiping themselves, when they're cleaning themselves after like passing stool. So these things are common causes of lower GI bleed in well-looking older children. But if they're unwell, like, coming in shock or something, then or not, even if it is not chalk, they look unwell, they look anemic, they are pale, they are thin, and they're generally unwell, then in that case, in older children, you should be thinking of inflammatory bowel disease. Inflammatory bowel disease is Crohn's disease and ulcerative colitis in children. Crohn's disease is more common as compared to ulcerative colitis. These kids, they usually have got weight loss, they've got like abdominal pain, repeated episodes of diarrhea, sometimes containing blood, like it could be trickles of blood, it could be fresh blood. And if you do a stool microscopy, you'll find that they've got like so many RBCs and white blood cells in the. But the best test for them is what we call as the fecal calprotect. It's a very sensitive test. Like normal values are 150 microgram per gram, and if it's more than that, it means that there's inflammation in the intestines. And then they, further tests can be done, like for example, lower GI endoscopy and taking tissue biopsies from the intestine to see the actual architecture of the epithelium and diagnose, because that's the best diagnostic tool. But nevertheless, fecal calprotectin. So if the child is unwell or looks like he's probably has got anemia and weight loss and is thin and is showing some signs of micronutrient deficiency as well, you should think of inflammatory bowel disease common in older children. Somebody who's got chronic liver disease can have backward increased pressures that can sometimes just bleed, or upper GI bleed or lower GI bleed. Both can happen in somebody who's got chronic liver disease secondary to whatever, like it would be primary biliary cirrhosis or chronic hepatitis B, C, whatever. But anyhow, chronic liver disease at the end stages, when the cirrhosis sets in, can cause like GI bleeding as well. Though causes more upper GI bleed than lower GI bleed, but nevertheless, it can sometimes cause intestinal ulceration. This usually happens in typhoid fever, enteric fever, appears patches, they get inflamed and they can ulcerate, and these kids are very unwell, prolonged fever, toxic looking abdominal distension, abdominal pain, things like that. So these kids, like older children, are unwell. So this way we can think of the different differentials which causes lower GI bleeding in different age groups of children based on whether they are well looking or unwell looking. Okay, so this way you can think of the common things that would be at top of your head. Now, how do we investigate? It's very important that we take a detailed history based on whatever age group is there. You take a detailed history. For example, if a neonate, you will ask if she's got cracked nipple, if she's breastfeeding, what was the mode of delivery, things. So you can think about that. And again, history and physical examination. But physical examination would give you so many important clues whether the child is well looking, unwell looking, whether he's got any stigmata of like a hemorrhagic disease, like for example petechia, purpura, things like bleeding from other orifices, or things like rashes, fussiness based on history, which point towards cow milk protein allergy. So history and physical, and part of the physical examination is looking at the diapers if they've got it, or their pictures if they've got it, and also even looking at the what you call the anal area, because if there's any fissure, if there's any visible bleeding, you can actually see that. So a very thorough, meticulous history and physical examination is important. That would like clarify the things probably in 80% of the cases. Then you also need to know what is a pattern. Pattern recognition is important, because something which is happening on a repeated basis means that there is something which is persistent and going on, rather than one-off or a few days, which can happen in, like, let's say, an acute attack of infectious gastroenteritis. So pattern recognition is important. So if it is an acute attack, if it's a recurrent attack, whether it's affecting quality of life, whether there are other like stigmata of chronic bleeding like anemia, things like that. After that, in neonates, one of the very good tests to differentiate between whether this blood is of maternal origin or whether this is of fetal origin is AB test. AB test tells you about that. Other than that, you can do, like if your child is unwell, you can do a full blood count to look at the RBC, if the child is anemic or not. You can look at the platelets count if they are low. You also need to look at the coagulation profile to look at the intrinsic and the extrinsic pathways. So it might be affected. Does it doing it a PT and APTT? INR and fibrinogen is a part of the coagulation profile, which you should do if you are considering something more sinister. As I said earlier, external anal examination is very important. Look for fissures or hemorrhoids. The rest of the examination really depends on what you are thinking. Like, for example, if you think that there might be rectal polyps which are causing repeated bleeding or something, then you have to scope them. So lower GI endoscopy in the form of proctoscopy and colonoscopy can be done depending on what you are thinking. And these are good because you are actually looking at the intestine from inside with the camera, and you can even take biopsies if needed. So lower GI endoscopy can be done in selected cases. Specialized tests, like in certain cases, if you think of Meckel's diverticulum, if it is the child is well, is having repeated bleeds, you can send them to radiologist for like technetium 99 scanning, which would pick up this ectopic gastric mucosa in the area. Or if they are actively bleeding, then another good test is radio-labeled RBC scan that can also be done in an acute Meckel's diverticulum bleed. And some people do double contrast barium for rectal polyps as well. As I think endoscopy is far better, superior, because not only diagnostic, can be therapeutic as well. And some of the simple test, abdominal X-ray, can be done as an initial investigation, especially if you think that there might be intussusception, there might be abdominal like some form of intestinal obstruction, or there could be necrotizing enterocolitis. So you can see many things like intramural gas or free peritoneal gas, etc., on an abdominal X-ray. An important screening tool for inflammatory bowel disease, if you consider that, is doing stool for fecal calprotectin. So fecal calprotectin should not be more than 150. And if it is more than that, like for example, more than twice, then you should be thinking of inflammatory bowel disease. And these cases, they need to be referred to gastroenterologists for further investigations and management. So this was all about how do you work up and think about differential diagnosis of lower GI bleeding in children, which usually presents as worried parent bringing their kid and say their babies or their children are passing blood in the stools. As far as the management is concerned, management depends on the underlying cause. Obviously, if somebody is acutely bleeding, you will go through your ABCs drill, airway, breathing, circulation, give them, if there is shock, you manage it accordingly. If they are anemic, too much anemic, bleeding actively, you'll give them back to RBCs. Or if they are anemic on a chronic basis, not active bleeding, you might put them on iron. And apart from that, the actual treatment is treatment of the underlying cause. So if it's a rectal polyp, the rectal polyp might have to be treated, ligated, removed. If it's inflammatory bowel disease, they need to be on anti-inflammatory medications or steroids, so on and so forth. So hope you've liked this video. If still got any questions, you can put your questions down in the comment section below. Okay, and ask me if there is anything which is not clear. And if you haven't subscribed to the channel, do subscribe. Share it with your friends, and I will see you soon. Signing off. Take care. Bye bye. Have a good day.